Abhirami, I think you are ready to present that.
Yes, sir.
Good evening, sir.
Oh, Sivathanu is going to present. Okay.
Sir, my topic is the classification of braking system and discrete braid circuits, sir.
Hmm.
So the braking system is some assembly of components which connects the patient's airway to the machine, which creating an artificial atmosphere. So based on the CO2 absorption, with the CO2 absorption and without CO2 absorption. With CO2 absorption, it is again divided into unidirectional flow and bidirectional flow. Unidirectional flow is a closed circuit system with absorber. That's a bidirectional flow is a to and fro systems. Without CO2 absorption, again divided into unidirectional flow and bidirectional flow. Unidirectional flow is a non-rebreathing system. It's a bidirectional flow. Again, it's a coming a Mapleson circuit system, which is again divided into afferent reservoir system and the efferent reservoir systems. It's a Mapleson A, B, C, and A modification latch circuits comes under afferent reservoir systems. It's a Mapleson D, E, and F, and the Bain circuits comes under efferent reservoir systems. Circuit, it is the modification of Mapleson D circuit. So Mapleson D is the most efficient breathing system during the controlled ventilation. So the Bain streamlined anesthetic breathing system was described by Bain and Sporel in 1972. It comprises of semi-open circuit, 1.8 meter length, of lightweight, with there's a corrugated plastic tubing of 22 mm diameter, outer tube diameter 22 mm, through which runs a small bore tube of approximately 7 mm diameter, which delivers the first class flow from the machine. The Bain system has to be adapted as universal anesthetic system because of both we can use both spontaneous and as well as controlled ventilation. And modification, the first class separate tube, the inner tube, which runs partially inside a corrugated tube and ends at a point where the fresh gas flow enter into the classic Mapleson D. It's a benefit of making it as coaxial circuit. It provides a self-contained, thermally efficient atmosphere where inspired gases are naturally warm and humidified. And also the tube within the tube design also eliminates the twisting between the inspirated and expired ends. And one more thing, the outer tube is clear here so that the inner tube can be inspected through the outer tube. And there's a functional analysis. Spontaneous respiration. First, during the inspiration, the patient will on the fresh gas inlet and corrugated tubing. Here, if the fresh gas flow is high, all the gases from the corrugated tube will be the fresh gas. If the fresh gas flow is low, some exhaled gas containing CO2 from the corrugated tube will also be inhaled. Rebreathing occurs. During escalation, the exhaled and it's moved through the corrugated tube towards the back. Once the back has filled, the gas exhaled via the APL valve, expiratory valve. During an expiratory pass, the fresh gas pushes the exhaled gases down the corrugated tubing through the APL valve. Vary from 100 to 300 ml per kg per minute to maintain a normal RPI. Most studies have written that the resistance flow being 1.5 to 3 times unit ventilation, unit volume. That is go so here the expiratory pass, the fresh gas flow fresh gas flow which continues from the inner tube and pushes the exhaled gases in the outer tube. So during the rest inspiration, when you fuse the bag, the fresh gas from the corrugated tube entering the patient, and if the fresh gas flow is here low, the rebreathing occurs. So the factor that will increase the rebreathing if you prolong the inspiratory time or increasing the respiratory rate. So rebreathing can be decreased by allowing the long expiratory pause so that the fresh gas flow flush out the exhaled gases from the corrugated tubing. And here a recommendation for fresh gas flow based on body weight vary from 70 to 100 ml per kg per minute to maintain normocarbia on and how to check the Bain's how to get a gentle inspection of the outer tube, inner tube, APL wall, and the reservoir bag for any kinking or any hole in the apparatus. And then we have to check a positive pressure test. It is for the outer tube and the APL wall, pattern C to check. Here we closing the outer tube with thumb. Then you close the APL wall completely. Then inflate the bag with O2 flush and wait for 15 to 20 seconds. Look for any leaks in the outer tube and the reservoir bag. Now gently open the APL wall. The bag deflates. Third thing, that inner tube occlusion test is a Crampton Smith test. Here the fresh gas flow is started 2 to 4 liters per minute. Now the inner tube. Now we have to plug the inner tube with a 5 ml syringe and look for any dipping of bobbin due to back pressure. And finally, the Pethick test, which also the inner tube test, occlude the patient end and close the APL wall and fill the circuit with the O2 flush. Now release the occlusion and then start a O2 flush. Due to Venturi effect, the bag deflates here, which means that in that inner tube. And the advantages of Bain tube, it is a lightweight, it's a minimal drag on ET tube as compared to metal circuit, and it's a low resistance circuit. As the outer tube is transparent, it is easy to detect any kinking or disconnection. And it is used for both spontaneous and controlled ventilation. And it's useful when patient is not accessible, as in MRI suites. And exhaled gases do not accumulate near the surgical field. Instead, the expiratory valve is near the machinette. So it reduces the airway fires. And easy for scavenging of gases, as scavenging system is at the machine end of the circuit. And also there is a warming of the inspired by exhaled gases in the outer tube. And some disadvantages also, because of the multiple connections in the circuit, there can be a chance of risk of disconnection. And the wrong assembling of the parts can lead to malfunction of the circuit. And a tighter pollution occurs due to fresh gas flow, but it can be prevented by scavenging system. And it is increased in cost due to increased fresh gas flow. And there can be a crack in the inner tube causing leakage. And it can't be used in pediatrics. And there can be leaking of fresh gas supply inner tube, blocking the fresh gas supply, leading to hypoxia. And thank you, sir.
Okay. You said it can't be used in pediatrics. Bain circuit
Can be used, sir, but it's because reservoir back is the volume is 2 liters, sir. So
you have a separate pediatric Bain circuit available. Okay, mainly used in gastroenterology endoscopic suits, where
yes,
this circuit is being used. Okay, and
yes,
there are persons who classified the classification. You started off with the definition correctly, but there are 3 persons who classified, mainly the Collins, Conway, and Cripps. Okay, so those classifications where they initially said it is open, semi-open, semi-closed, and closed. Then somebody said it's insufflation, semi-open. So that word I didn't hear in your presentation at all. That classification of open, semi-open, semi-closed, and did you mention about that?
no, sir. I forget that. I don't know that.
So that is a very important point that has to be included. So I'll just show the presentation how to deal with that particular.